kept very high risk atherosclerotic cardiovascular, either clinical or unequivocal on imaging, that is CT scan included in these guidelines. That you have picked the disease by means of CT, their target should be less than 55 in both primary and secondary prevention. So even the primary prevention group is included in that LDL-C target of less than 55. If your patient is coming in this group, very high risk. And in selected patients of these high risk group, now the target of LDL is less than 40 milligram per deciliter. Meaning the previous very high risk, which was previously targeted for less than 55, now the updated guidelines are suggesting them to have a target of less than 40 LDL. And what are the categories? Like diabetics with target organ damage, long-standing duration greater than 20 years, or associated with other risk factors. So even without atherosclerotic cardiovascular disease, a high-risk diabetic is in very high-risk group. Similarly, patients with CKD, familial hypercholesterolemia, risk score greater than 10%, and subsequently you can see that with the second group, the target is less than 70. So all those targets are really brought to much strict range that previously which was less than 100, now is less than 70. Previously which was less than 70, now it's less than, and few more groups are added on that category as well. Similarly, moderate risk less than 100 and low risk, which was previously 130, now it's 116 to achieve in terms of. So that's the key, that now the LDL targets are very strict. And these are all evidence based. We know that the low the LDL, low will the chances of having subsequent events. Now the importance is how to achieve these targets, how to incorporate your drugs with baseline LDL consideration. Will just statin be enough to achieve this target, or we may need other? Now we have 4 or 5 agents, so we'll go through them to see how they are. These are some few things of your guidelines that non-HDL should be looked at, that is total cholesterol minus HDL along with LDL level. ApoB analysis and lipoprotein A, which I already have discussed, should also be measured. I don't know whether it's available right now or not. Now coming to management, changing management strategy, because if you look on to the previous 2018 guidelines, you are having statin, and if your patient is intolerant to or you are unable to achieve target, then you have ezetimibe and PCSK9. These 3 drugs were discussed in previous guidelines. Now you can see that addition of these, and I'm just picking this part as a separate. You can see now optional intervention to consider in appropriate patient group. Refer to lipid specialist, ezetimibe, bile acid sequestrant, PCSK9, bempedoic acid, inclisiran, LDL apheresis, lemipitide, evinacumab, and few of them now are available to us as well. Some are very expensive to offer, but ezetimibe we usually are using, and now we are having this bempedoic acid as well to add on to our statins to achieve our targets. And how to incorporate them, that we'll see. That if you're unable to achieve, if you're achieving target like less than 55, although this algorithm was the American consensus document, the European are now saying target even less than 40 in some patients. So if you're not achieving target, well enough, just observe them. If you're not achieving target, you have to consider non-statin therapies in a way that you can add on PCSK9, ezetimibe, bempedoic acid. These 3 drugs which are commonly available to us. So adding these 3 drugs are needed to achieve our targets in different groups of patients where we are unable to achieve our targets with statin. Just I quickly go through the common features which you can see in your patient for statin intolerant, because sometimes, usually with even pre-existing higher doses, we tend to increase the dose of statin, which is logical that you can go up to the maximum dosages of statin. But if your patient's baseline is such that they are showing all those features which can cause statin tolerance, I think that's the point where you have to add on rather than increasing. And we'll see in a moment evidence based that increasing statin, how much of LDL reduction you can achieve with statin, increasing statin. But certainly, if your patient is young enough to tolerate the maximum dosages, all the guidelines suggest that give maximum dosages of statin before adding on. But sometimes you're clear enough that even with maximum dosages of statin, you're not going to achieve